In spite of the decision of World Health Organization, the regulatory agency here in Nigeria, the National Agency for Food, Drug Administration and Control, NAFDAC, says it will continue hydroxychloroquine clinical trials for the treatment of COVID-19. NAFDAC Director-General Prof Mojisola Adeyeye says there is data to prove that the drug worked for many COVID-19 patients, especially those at the mild stage of the virus. Therefore, Nigeria will continue clinical trials. You would recall that Lagos State has already begun hydroxychloroquine clinical trials, and conclusions are expected in 3 to 4 months.
Meanwhile, a total of 16 COVID-19 patients were confirmed on Tuesday. This was announced by the Nigeria Center for Disease Control on Tuesday night, when the agency published the latest COVID-19 update. NCDC also confirmed 276 new COVID cases in 15 states across the country. Lagos recorded almost twice its figure for Monday, as the state moved from 90 new cases the previous day to 161 new cases on Tuesday. A total of 8,344 confirmed COVID-19 cases have now been recorded in 34 states and the Federal Capital Territory. The number of discharged persons rose from 2,311 to 2,385, while fatalities increased from 233 to 249.
And for more on Nigeria's effort in tackling the coronavirus pandemic, the Minister of State for Health, Senator Adeleke OLORUNNIMBE Mamora, joins us live from our Abuja studios in the nation's capital. Great to have you, Senator Mamora. Thank you so much for joining us.
Thank you very much, Adesua, I believe.
Let's begin with the most recent developments, which is on the hydroxychloroquine. The World Health Body has put a pause on it, citing safety concerns. But the regulatory agency here in Nigeria, NAFDAC, which is under your ministry, says as we go ahead with those clinical trials. Is this in line with the ministry's determination to find a cure for COVID-19 in Nigeria and treatment? If it is not, why is NAFDAC going ahead?
Well, by virtue of the role that NAFDAC plays in the country, it's important for us to do our own checks and rely on our own findings. Yes, the WHO is there as the world body that regulates and takes decisions and makes recommendations. But in spite of all this, it is not out of place for us as a nation to look at the realities of our own situation. And if a particular drug appears to be promising one way or the other, it will not be out of place for us to engage and embark on a clinical trial in respect of that drug. Don't forget that for us here in Nigeria and possibly the whole of Africa, chloroquine is not really new to us. For ages and for quite some time, we were using chloroquine, though not for the treatment of COVID-19, which is a new disease, but at least while we were using it, it was well tolerated. And in this circumstance, of course, we know that there are issues of toxicity, that is being toxic to, particularly for patients with heart disease and the like. But notwithstanding, it's not out of place for us to still carry out our own studies and have findings that are based on the realities of our own situation and what we find from our own experience.
Right, sir. I just want to go in the line of drugs, and I want to talk about herbal medicine. What has been the push as regards, herbal remedies? We heard some time ago about Professor Maurice Iwu and a couple of other people that have brought forward herbal alternative, to be able to fight COVID-19. What has been the state of herbal remedies? And I want to know also about the Malagasy drug COVID organics. Is the test done? Has it started to be issued to a couple of people in this country as trials?
Well, the drug from Madagascar, COVID organics, all I can say for now is that they are yet to be received formally in the ministry. But I am aware that the chairman of PTF has mentioned that the drugs will be sent to the Ministry of Health. And Ministry of Health will then forward the drug to NAFDAC and other agencies like NIPRID, that's the National Institute of Pharmaceutical Research and Development, who will do the necessary checks and analysis of these drugs before we can decide whether we will use the drug or not. I mean, it's a procedural thing. Then back to the issue of herbal remedies. You will recall that last week, I think just about a week ago now, precisely on Thursday last week, we had a virtual meeting with the herbal practitioners and traditional practitioners who have made claims and submitted same to us in the ministry through the Department of Traditional, Complementary, and Alternative Medicine. So those of them that made these submissions, we decided to reach out to them and engage them in a virtual meeting. Some of them were, about 5 of them were physically present with us at the conference room where we had the engagement. And also present at that engagement were the heads of the various agencies, NAFDAC, Nigeria Institute of Medical Research, that is NIMA, the NIPRID, that is the National Institute of Pharmaceutical Research and Development. We also had in attendance the president of the Pharmaceutical Society of Nigeria, that's Mazi Ohambua. We also had in attendance virtually academics who, with a long history of commitment to development of herbal practice in Nigeria. One of them from the Adeleke Mamora University Faculty of Pharmacy, and another one from the University of Benin Teaching Hospital, who has also been a long-standing professor with commitment to developing herbal and traditional practice. So these people were there. Of course, we also had in attendance the chairman of the Ethics Research Committee, because there are some ethical issues that naturally will come to play when you are dealing with herbal research and the like. So it was a very exciting engagement where these people with claims, 19 of them in number, one by one, made their presentation, telling us the name of the drug or the remedy, telling us how it works or what they think it's going to do, whether it just has to do with remission or mitigation of symptoms, or it's outright cure. So they made their claims. Of course, we were able to ask them whether those drugs or remedies had been submitted to NAFDAC, which is the first port of call in terms of determining the fitness for human consumption, because that's the first thing that has to be sorted out. That is it fit for human consumption before the other processes? And of course, these other processes include further analysis by the National Institute of Pharmaceutical Research and Development, and of course, the clinical trial and what have you. So that's where we are right now. So we've been able to have this engagement, we'll be able to know what their challenges are in terms of getting things done. And we are able to explain to them what they also need to do, their challenges, and where we need to come in. All
right, Honorable Minister, talking about challenges, let's talk about testing. Even the WHO had recently said that there are concerns over testing in Africa, that it could be leading to a silent epidemic. Just yesterday, the NCDC announced the activation of 2 more labs in Nigeria, bringing the total to 28. Commendable. However, if we look at the number of tests we're doing daily, we're still doing below 1,500 most days. What seems to be the challenges, and why are we not testing enough?
Well, you see, it's a function of so many factors. One, you using the PCR, what we call the polymerase chain reaction testing mode. That is the one that measures the viral load, and it's the most authentic, is the most accurate, and the most reliable, as opposed to using what we call the rapid diagnostic test kit, which, again, by WHO recommendation and from what we have seen, is liable to a lot of errors, high error margins, and which could be as high as 40 or even 50% in terms of results. So you may have false negative or false positive. So the PCR thing, the PCR-based test that we do, takes a lot of time. The rapid diagnostic test will probably take about 15, some 20, some 25 minutes, some 30 minutes, depending on where it's coming from and how it works. But we have confined ourselves to the PCR, which takes longer time. But having said that, again, you also have the issue of logistics in terms of delay between sample collection and the actual delivery at the various labs, and then the turnaround time. That is, even after the samples have been delivered, how much time does it take to get back to to those who really submitted themselves for such tests. And the third issue is that of coordination. Coordination in the sense that from every state and the Federal Capital Territory, no test result is announced without taking it through the governors of the states, of the respective states, and of course the minister of the Federal Capital Territory. It's just to be sure that you are not missing anything and that you're on the same page, so that when these figures are announced, there won't be a contestation as to whether that is a true figure or not. So all this put together are some of the factors that are responsible for the slow rate in terms of the number of tests done.
Okay. I just quickly want to further on the issue of tests. What is happening in Kogi and Cross River State?
Yes, in Kogi, we had some issues. Maybe I should just call it a communication gap between the federal authorities, particularly the NCDC officials and the state officials. There were some communication gaps in, and that delayed. Where there was some kind of misunderstanding arising from this communication gap. But as it is now, we're getting over that, and there is some degree of amity and better understanding of rules right now. So I think the officials of both the federal and the state are now working together to achieve the same purpose. It's the same thing that we had with Cross River, and I can tell you that the team sent to Cross River was received by the governor very well, and the initial misunderstanding or gap is no longer there. So because we need this engagement on a regular basis so that we can work together for our own common good. So we had some initial issues that had since been sorted out.
Let's talk about case management in Nigeria. The PTF has been hinting a change in policy to hospitalize moderate to severe cases. But with the numbers we are seeing, over 8,000, would it be correct to say that policy has become operational in practical terms, especially in a state like Lagos, that continues to record that high number, the epicenter of the disease in Nigeria? What is the isolation capacity like at the moment, Minister?
Well, the truth is that, yes, I did say earlier on that the WHO, as the apical body, globally, that tends to advise and recommend. But in spite of all that, the truth still remains that WHO will not dictate, The WHO will only give you the broad policy guidelines to be followed or recommended. But individual countries and states will still be left to do that which is needful in the circumstance. So what I'm saying in essence is that it's just like, of course, every country is supposed to have one national approach. But this one national approach does not necessarily now say that it's going to be one size fits all. No, you have to look at the realities in your own situation and use such realities to determine what best to do in the circumstance. So it leaves room for flexibility. It leaves room for innovation. And of course, it leaves room for determining what to do based on the circumstance in place. So we cannot, there is no way that you can have enough isolation beds for positive cases. It's not possible. So you are now forced to look at home treatment. You are forced to look at home isolation, but supervised with a view to really monitoring what is going on, and between the patient and the caregivers. And of course, you need this cooperation. And it's important for people to appreciate that they are the ones that necessarily will have to take the primary responsibility for their health. That is very important, and we cannot overemphasize that. So if we ask someone to be in self-isolation, and that person fails or refuses to do that, don't forget that in the first instance, that person will be exposing his family members to risk, primarily, before even exposing others. So I'm saying that it becomes inevitable if the realities on ground are such that will not make isolation in a public space or public setting be conducive.
You're saying that at the moment we do not have cases, it's not become flexible at the moment. We have all these numbers in the isolation centers. And if that's not what you're saying, how many of these confirmed cases are receiving home treatment and are being followed up?
Well, that will not be determined from the center. It will only be determined by each state that is putting such measures into place. So I will not be able to tell you that these are the numbers. And of course, it's a dynamic situation. So what is going on in Lagos as an epicenter would not necessarily be the same that is going on in Abuja, or that is going on in Kano, or in any other state or territory that is an epicenter. But what is important at the end of the day is to ensure that the patients appreciate why the particular measure is being put in place. So when you talk of self-isolation, it is because we want to limit if not completely eliminate, the chances of infecting others around such a person. So if that is understood, then we will get the right results.
Okay.
That's simply what it means.
Okay. We do have reports by our sister outfit, This Day newspapers, that mortuaries are overflowing in the following states: Cross River, Edo, Kogi, Imo, and Lagos. Is there a possibility that these deaths are related, COVID-19 related, and we are underreporting COVID-related deaths in Nigeria?
Well, anything is possible. Don't forget that what we are doing has to be based on data, evidence, and of course, science. Those are the three things that all these things will be determined by. So, if we are not getting the right data, if we are not seeing the evidence, if we are not following science, it will be difficult to determine that this is what is happening. But having said that, we do know that unexpectedly too, because of COVID situation, which creates a lot of anxiety in both the caregivers and even the would-be patients, you have a situation where patients themselves may not readily go to hospital because they are anxious. They are afraid of not getting infected. You also have a situation where even caregivers, particularly frontline doctors, nurses, they may be afraid in terms of the patient they are seeing. Is it a COVID-19 case or not? That's also an issue. And particularly in a few cases where the issue of non-availability of personal protective equipment, PPEs, becomes an issue. So when you put these two together, one way or the other, it's going to even compromise the routine cases. For example, a patient coming in with a diabetic coma, and then you are not too sure what that patient is coming up with. So the first thing is you want to determine the COVID-19 status of that patient, so that you as a physician attending to that patient, you want to be sure that you are safe yourself, and of course you want to be sure that even the patient coming in wants to be sure that he or she is not being exposed to another risk. So to some extent, the routine cases that even go to hospital would normally reduce in number. Secondly, because of the circumstances, of course, when you have this lockdown and the restriction in movement and all that, so patients that even ordinarily want to go to hospital, they may be limited because of these restrictions. If a patient is supposed to go to hospital maybe in the night, but because of lockdown, because of curfew, the patient may not readily go, or there may not be availability of transportation medium to get that patient to hospital. So these are some of the things, and there is no way that the routine medical services will not be affected. But our approach has been to, as much as possible, to continue to encourage the various treatment centers, hospitals, teaching hospitals, federal medical centers, general hospitals, to ensure that the routine services still go on. Even things as basic as immunization, it's important that all this still go on, irrespective of the COVID-19 situation, which is compromising everything: social life, economic life, name it, cultural life, religious life. So these things will naturally affect. So you may now end up with a situation that there is rise in morbidity, there is rise in mortality. So these are the things we are seeing. And of course, we continue to look into all this with a view to really ascertaining what exactly is happening. Are they COVID-related, or are they completely different things happening?
Okay, let's bring in the issue of the participation of private hospitals, which was which created a lot of controversy initially, as government promised to register more of them to participate and respond to the fight of COVID-19. Can you tell us how many private hospitals across the country have now been given the go-ahead to participate and respond to COVID-19 treatment in Nigeria?
Well, I cannot give you the figures right now because what we do from the center is to just issue the guidelines to the various states and the Federal Capital Territory. We see by law, it is the individual state that determines who is registered at the end of the day. And the FCT, which is treated as if it were a state. So that's why you see a registration board or registration authority for each state. The statutory instrument is vested in each of the states. So I cannot give you that figure right now, until and unless we collate these figures as submitted to us through, or by the various states. But statutorily, this is a function of the state. All we do is to just send guidelines to them.
All right, Honorable Minister, if you can hear me, I want to talk about what is currently going on with CAN and the Supreme Council of Islamic Affairs, having a meeting as regards formulating guidelines to be able to return to the churches and mosques. Do you know anything about that? And are you part of that meeting? Are they sending these guidelines to you as they're talking?
Yes, they are reaching out to us just as we are reaching out to them from the PTF. They are reaching out to us at PTF, that is the Presidential Task Force, and the Presidential Task Force is also reaching out to them. We have this engagement, and yes, one of them I'm aware. And don't forget that the argument, initially was that, well, if in spite of the non-pharmaceutical interventions that we are making, and we can still allow people to go to market where a lot of things go on, why would we want to stop people from going to church as well? That was the argument, initially. But thank God, and I want to thank our religious leaders, particularly His Eminence, the Sultans, and the Sultan, who is the supreme leader of Muslims in Nigeria. And the same thing, I want to thank that's Dr. Ayokule, His Eminence, also the leader of CAN and the president of CAN in Nigeria. They've shown tremendous, and I mean tremendous, understanding in the face of pressure from the adherents of the two major faiths in Nigeria. But they have shown tremendous understanding. So now, the thinking is that, yes, as we are moving gradually to relaxing some of these measures, regarding lockdown, yes, that we might be able to have an understanding as to how, if they are coming up with proposals, which we are looking into, as to how they can still reasonably comply with physical distancing, social distancing, and of course, all other non-pharmaceutical interventions, washing of hands with soap and water, use of sanitizers, use of face masks, and all that. So they are putting across to us suggestions, proposals that we are looking at, and which we hope that at some point we will be able to have a good understanding and have a middle road position that we can say, okay, you can resume your congregational worship. For example, if you have a parish that normally has maybe 100 parishioners worshiping at a given point in time, you can have a situation where you reduce that to maybe 1/4 of that, so as to have physical distancing of worshippers. So you now have 25 out of, instead of 100. And of course, you can then see if you can have many services, maybe instead of one service per day, you can then increase your services maybe to about twice or thrice, depending on how you look at it, so that you can then reduce the number that come together at a given point in time. Of course, in addition to other measures, the use of face masks, hand washing, use of sanitizer, and all this will still be there. So, but we are looking at this, and again, I want to really salute their sagacity. I want to salute them for their understanding. So we are looking into all this, and we'll come up with something that will be mutually, agreeable.
Minister, if you don't mind, I would like to take you back to the issue of hydroxychloroquine. Nigeria is insisting it's going ahead with clinical trials despite WHO's warnings, and you have said why. But what is really promising about this drug? Have we seen any efficacy? Have we seen any promises from this drug that makes Nigeria want to continue with these clinical trials?
Well, you see, I did mention earlier on that three things come into play: science, evidence, and of course, data. Those three things are by and large what dictate what you do or what you believe. And when we talk of clinical trial, you are looking at, don't forget, the fundamental thing is that there is no drug right now that you can say cures COVID-19. None in the entire world. But what we are saying is that from those three things I mentioned, from science, from data, from evidence, we've seen a situation where it will appear that certain preparations, certain products, certain remedies, certain drugs, they tend to do certain things within the human body as to make, maybe to reduce the symptoms or reduce the length of stay in hospital. That if the average patient normally is hospitalized for about 10 days before you can say, yes, this patient is getting well or is well enough to be discharged. If you have a drug that will make the period of stay or hospitalization to be shorter, maybe to 7 instead of 10, then you can say, then there must be something that we need to look at in this drug. Again, if a patient that comes in with difficulty in breathing, and maybe with the application of a particular remedy, the patient's breathing improves, or other symptoms, maybe the fever, if the fever improves with the administration of a particular remedy, then you may start looking into what has happened. That's why we talk of clinical trial. You will now start to, you may know, that's the whole essence of science, that what has happened that made this possible in this particular patient or in this number of patients. So these are the things. And we are saying the clinical trial is for us to be able to look into this, in a scientific way, and based on evidence and based on data from us. I repeat, from us, from Nigeria, not the data in the US, the data in UK or in Belgium or in France. No, we are talking of our own data because that's what we need.
Okay. Real quickly, sir, I want to talk to you about vaccines. And I'm talking about this because the vaccines arm race has started. A lot of people are trying to get vaccines for this. But even if they get a vaccine, we're still going to be shortchanged here because we don't have a vaccine factory where we produce vaccines. We used to have one in the 70s and 80s. What's the state of that place now? Is the government doing anything to revamp that place? And secondly, I want to talk about Kano. We all saw what happened over the weekend as regards Eid al-Fitr prayers in Kano. That was the height of social distancing, I'm going to say ironically. What's your take on that? I want to talk about that real quickly. Those two questions, sir.
Right. Thank you very much. That's Rufai, I believe.
Yes, sir.
Now, yes. Now, in the issue of vaccine, yes, it's a pity that as I always say, it's like somehow, yes, in the 50s, late 50s, early 60s and all that, Nigeria was a producer of vaccines from the laboratory in Yaba. But somehow, somewhere along the line, we seem to have undertaken journey into decline. And then along the line, we were no longer producing vaccines and all that. But those are the the good old days. But then, those good old days can still come back. So, as we speak right now, there is a committee in place that is working with private concerns to be able to start vaccine production in Nigeria. And that body is really working, I can tell you. Of course, when you talk of vaccine production, it's usually a collaborative effort, not necessarily just due to one individual or one group or one body or one agency. It's usually collaborative because you need so many input. And I do know that the Nigeria Institute of Medical Research, that's NIMA in Lagos, is working, in collaboration with this group and other groups as well, so that we will not be left behind. And of course, don't forget that Nigeria is a participant in what is called the Solidarity WHO modulated solidarity vaccine production. We are also part of that. Some states have registered as individual states, and of course coming from Nigeria. So we'll wait to see the outcome. And of course, vaccine production takes a lot of time. You cannot have before a vaccine gets to the market, it will undergo so many trials, clinical trials, and what have you, to check the efficacy, to check whether there is toxicity, that is, whether it's dangerous and all that. You have to. So it takes not less than 18 months to 2 years for you to have to come up with one. But I can assure you that we are not left behind in that exercise. Yes, Kano. Yes, I can tell you that we are as worried as you are as to congregational worship that took place for the end of Salah and all that. Well, we would have wished that it didn't go that way because of the need for this physical distancing, which apparently will be difficult to observe in that kind of situation. But the way it is, the issues of faith are such that you have a lot of passion, and you have a lot of commitment, and we can only advise from this end. And again, the individual states, they also have the onus to put in place what we have recommended by way of advice. It will not be possible for us from the center to, do the enforcement from this end. We will ordinarily leave the states to do the enforcement and do what they also consider desirable in the circumstance. But we would have wished that it didn't go through that process the way it did.
Very briefly, Minister, if you can, in 20 seconds, what's the most valuable lesson Nigeria is learning in this pandemic?
Well, probably the most valuable is that we need to go back to the basics and rework our healthcare system. If the countries that were ordinarily referred to as doing well in their health system, if COVID-19 came and made nonsense of that health system, you can then imagine our own situation where we didn't have in place a health system that you can really say, even in the best of circumstances, that
Thank you so much,
is what it should be.
Honorable Minister of State for Health for Nigeria, Senator Mamora. Thank you so much for coming to Arise Newsday today. We do appreciate it.